Good afternoon. My name is Ana Sofia Ore. I'm a surgical resident at Beth Israel Deaconess in Boston. Thank you for allowing us to present our work today on the evaluation of racial and ethnic disparities in surgical management of inflammatory bowel disease. We have no disclosures. US Census data predicts that 54% of the US population is going to be represented by minorities by 2050. Out of this, Black and Hispanics will contribute to 45% of the population. We also know that there's studies that have shown increased prevalence of IBD among minorities. Despite this, diversity in race reporting in large prospective studies, including national databases, remains low. We do know that disparities exist in the care of IBD patients. We also know that this is multifactorial. It starts with delays in diagnosis, differences in insurance and coverage of cost of care, access to IBD specialists, and genetic differences, environmental differences, and there's many other factors. Studies have also shown that Black patients with Crohn's disease have higher complications due to rare disease, and Hispanic patients has less access to biologics and immunomodulators compared to their non-Hispanic white counterparts. When we look at outcomes after surgery, reports vary. There are many studies that show that outcomes after surgery are similar for patients of same race and different races and ethnicities, but some reports show that Asian patients have longer length of stay. Some other patients show that Hispanics have increased readmission rates, and that Black patients overall have worse complications after surgery. Knowing all this, our goal was to evaluate post-operative morbidity and outcomes in patients undergoing IBD surgery of different races and ethnicities, and doing an independent analysis of both Crohn's and UC, and adjusting for the variables that we think could be impacting care preoperatively. So for our study design, we did a retrospective cohort using NESCIP data from 2012 to 2019 and merged it along with the proctectomy and colectomy data. With this, we identify all patients undergoing surgery for both Crohn's and UC, and we divided them in 4 categories: non-Hispanic white, Black patients, Asian patients, and then Hispanic white patients. All emergent cases, cancer cases, and patients without race or ethnicity were not included in our analysis. So our primary outcome was composite postoperative morbidity. Composite postoperative morbidity is a metric designed in order to account for all morbid events that happen in the first 30 days after surgery. If any patient had one or more of these events, they counted towards the group of postoperative morbidity. These include organ and space surgical site infection, anastomotic leak, reoperation, sepsis or septic shock, pulmonary embolism, stroke, MI, death, or an index length of stay of over 90% in the percentile for the group. For our analysis, we initially identified the rate of composite postoperative morbidity for each of the races and ethnic groups, and then later found all the factors associated with an increased or decreased risk of this using a multivariable regression analysis. As a secondary outcome, we perform a propensity score 1-to-1 matched analysis using non-Hispanic white patients as the control group and matching them to patients of different races and ethnicities. The factors we used for our propensity score analysis were the factors identified as risk factors in our first regression model, along with known variables to affect IBD care. These are our initial results, which shows that 12,043 patients were diagnosed and underwent surgery for Crohn's disease, and 6,699 patients underwent surgery for ulcerative colitis. As you can see here, both groups had predominantly white patients undergoing surgery. The second largest group for Crohn's disease was Black patients with 9.9%, and for UC, the second largest group was Hispanic patients with 5.9%. Going immediately to our primary outcome, which was composite postoperative morbidity, we're looking here only at Crohn's disease. We see that the highest rate of composite postoperative morbidity was for Black patients with 27.5%, compared to 17.4% from their non-Hispanic white counterparts. We also did a regression analysis, as mentioned, and we identified factors that increased or decreased the odds of having composite postoperative morbidity. We found that female sex Normal preoperative albumin and an MIS approach were factors that decreased the odds of composite postoperative morbidity. We found that tobacco use increased the odds. And you can see on your right side, we did a breakdown by race and ethnicity of which of the races had an increased association with composite postoperative morbidity. And the only race that was associated was Black patients with an OR of 146, and this was statistically significant. When we look at composite postoperative morbidity for UC, we see the same trend. Black patients had the highest rate of composite postoperative morbidity with 26.1% compared to 18.2% of their non-Hispanic white counterparts. Factors that decreased the odds of composite postoperative morbidity were female sex, normal preoperative albumin, and an MIS approach. Factors that increased the odds of composite postoperative morbidity were tobacco use, a BMI over 30, and once again, when we did the breakdown by race and ethnicity, Black patients were the only ones that were found to have increased odds of composite postoperative morbidity in our study. As a secondary outcome, we performed a propensity score 1-to-1 match using factors that were found in our regression analysis plus factors known to affect IBD care. From this secondary analysis, we found that for Crohn's disease, Black patients had longer operative times. We found that Asian and Hispanic patients had higher rate of ostomy creations. Black patients had higher transfusion rates, had higher deep and organ space infections, and they had longer length of stays. When we look at UC, we found that Black patients had longer length of stays and longer readmission rates, higher readmission rates. So to conclude, we found an increased risk of composite postoperative morbidity in Black patients after surgery for both Crohn's disease and ulcerative colitis. After propensity score matched analysis, Black patients were still the group with worse outcomes after surgery. We also found an increased stoma creation rates in Asian and Hispanic patients, which was later confirmed with our propensity score analysis. This study has the limitations of a retrospective and large database analysis, which include the use of CBT and ICD codes, and also the fact that there is a risk of missing data. But most importantly, there are some variables specific to IBD care that are not available in NSQIP, such as use of biologics, immunomodulators, type of insurance, and then access to a specialist. So to conclude, actionable items such as increasing health literacy and preoperative optimization are needed in order to increase the care of our patients, both with race and ethnic minorities in this country. We need to increase and diversify race reporting in both prospective and large database studies. With numbers showing increased number of growth of minorities in the US, why are we not increasing race and ethnic reporting in research? Thank you, and I'm happy to answer any questions.